So my job today is talk about uveal melanoma. Uveal melanoma is a rare disease. It's a disease for which the prognosis has been very dim, but we have made substantial progress in treating this disease over the last several years. And so I'm going to review some of that data, and these are my disclosures. And this is a slide that Dr. Orlov presented in ASCO in 2019, and I modified a little bit because I had to add some recent information. But essentially, it shows that uveal melanoma and cutaneous melanoma are not the same disease. They come from the same cell type, the melanocyte, but they're different in many, many ways. Beginning with the incidence, uveal melanoma is a rare disease. It's about 4% of all melanomas. We don't know what causes uveal melanoma. We have some clues, but we do know what causes cutaneous melanoma, which is mostly UV radiation. The mutation profile is very different in uveal melanoma than it is from cutaneous melanoma, really explaining why these are two different diseases. You manage these diseases differently. Cutaneous melanoma is managed by surgery and maybe sentinel lymph node biopsy. Uveal melanoma is managed by local treatments of the primary tumor. The way you figure out who is at high risk is different. In cutaneous melanoma, we look at the stage, we look at lymph node involvement, we look at some gene profiles. In uveal melanoma, the best way to determine prognosis is a gene profile and the staging system. The pattern of metastases of presentation is different. Uveal melanoma, 50% of the time presents with metastasis only on the liver, and up to 80% of patients will have metastasis in the liver and other areas. The treatment is really the most marked difference. We have a lot of treatments, as you have seen this morning, for cutaneous melanoma, but there's only one approved treatment, which was just recently approved for a specific subset of patients with uveal melanoma, the patients that have HLA-A201 immune type. And that treatment is tebentafusp, and we're going to be talking about that, of course, as it goes. So uveal melanoma can occur in different parts of the eye. The most common part is in the choroid, which I'm not sure you're seeing my arrow, but if you are, I'm pointing to where the choroid is. Another is melanoma of the ciliary body, which is here, and the other is melanoma, uveal melanoma of the iris. So very briefly, what are the treatment options for the primary tumor? In the past, these patients were treated with enucleation. At least in the United States, we rarely do enucleations. Now, we only do that when the tumor is invading the orbit, when the vision is irreversibly lost. In those cases, sometimes patients undergo enucleation. We mostly use plaque brachytherapy, and you see an example here of plaque brachytherapy. It's a plaque that has radioactive material, and you leave that in usually for 3 days while the patient is in the hospital. You take it out after 3 days, and patients go home. And this has a very, very good control rate of the primary tumor. Rarely, we're beginning to use proton beam radiotherapy more in centers that they have proton beam available. Local resections are not very common. And for patients that have very, very small tumors, sometimes laser hyperthermia is used. So for patients that present with disease in the liver only or mostly in the liver, there are several ways that we can treat these patients. We can do what's called hepatic-directed therapy. There are some ablative forms of hepatic-directed therapies, including surgery, including killing the tumor with radiofrequency ablation, which you put a probe in the tumor, and you have these radio frequency waves applied to the tumor. You can also cook the tumor with microwave ablation or freeze the tumor with cryoablation. And there is stereotactic ablative radiation, which is a form of localized radiation therapy that can be given to the tumors. There are also other approaches in which you use the circulation in the liver to kill these tumors. You can embolize the tumor, meaning you get into the hepatic artery and you throw little emboli there that will clog the tumor, clog the circulation. We can do just that, or you can do chemotherapy administered at the same time, or you can send microscopic radioactive spheres into the tumor that we call CERT or Y90, and that can also treat those tumors that are being embolized. Or how it's done in, for example, Philadelphia, they do they do embolization with immunotherapy drugs given into the tumor as well. And there are also newer approaches that are not embolic. There's hepatic arterial perfusion and isolated hepatic perfusion. And these are procedures in which the circulation of the liver is cut off from the systemic circulation, and high doses of chemotherapy are given to the liver and stay mostly in the liver. And these have been effective in decreasing the tumor burden in the liver. The problem with that is that these have been open approaches, so it's big surgery. More recently, percutaneous hepatic perfusion given by special catheter called Histotripsy has been approved in the United States and has been used more frequently to treat these patients. So there's some novel liver-directed approaches. There are combinations of liver-directed therapy. For example, these percutaneous perfusion is being tested with a combination of ipilimumab and nivolumab. We are doing a trial here at Sylvester using radio embolization followed by tebentafusp in patients that can receive tebentafusp. There are trials looking at stereotactic radiation and nivo-rela. This is a study that we were one of the centers using a drug that stimulates the innate immune system, given directly into the liver in combination with immunotherapy. There are also tumor treating fields, which is a technique that has been approved for brain tumors and now being tested in uveal melanoma. And there's histotripsy that I'm going to talk a little bit about because I get a lot of questions from patients about histotripsy, which is a relatively new liver-directed modality. And here you see what histotripsy is. It's really a very focused amount of ultrasound waves that are given directly to the liver tumors. And it's non-invasive. You can see here that the ultrasound really creates this cone. And with this cone, you can target the tumor. And what happens is the tumor becomes like this kind of bubbly and it dies. And the thing is that there really isn't a whole lot of data of histotripsy and still a procedure that we really are waiting for a lot more data before using it more extensively. There aren't too many centers in the US that are doing this, but there are some. And here is just show that it is non-invasive. This seems to be the main advantage. Patients lying down, this machine comes and creates that cone of ultrasound waves. So when the disease is more extensive, we have to think about systemic options, chemotherapy, targeted therapy, immunotherapy, and cell therapy. I'm going to spend 2 seconds on chemotherapy. Basically, these all these studies, what they showed is that chemotherapy, it very, very rarely or never works in uveal melanoma. So most of the time, we don't even bring that up as a legitimate option for patients. So I'm going to move on now to targeted therapy. So targeted therapy is therapy that's targeted to the molecular pathway that leads to the stimulation of the tumors. And this is the molecular pathway for uveal melanoma. These are the G proteins here, and it goes this way to the protein kinase C and to the RAF/MEK/ERK pathway. This is another way in which that these cells can be stimulating, going to the PI3K pathway, AKT, mTOR, and this is a non-traditional pathway through YAP that can activate the tumor cells. What I really want to point out here is that we have tried, we as a scientific community have tried over the years to intervene in a lot of these critical points on the pathway. And as you can see, the results have not been impressive. We have not seen major responses. We have not seen prolongation of survival, but there is hope. Very recently, this drug that works on protein kinase C called darovasertib has shown the potentially a very broad impact in the treatment of uveal melanoma, particularly when it is combined with another drug called crizotinib. Crizotinib works on this part of the pathway, on MET, not this part of the pathway, it's MET. And when these two drugs are combined, we see really remarkable responses in metastatic uveal melanoma. And this is the data from the phase 1 trial. And you can see that there were 30% of the patients had a partial response, 60% of the patients had stabilization of the disease, only 11% of the patients progress. And in these patients, there was shrinkage of the tumor in 92% of patients. So this is quite impressive. And Dr. McKean actually was the person that presented these data in an international meeting a couple of years ago. And this data led to this clinical trial in which patients that have to be HLA-A201 negative. And the reason for that is that there is an approved first-line trial for HLA-A201 positive patients. And this trial is, this initial phase here is completed. So the trial is now at this point in which we have determined a dose for the combination of darovasertib and crizotinib, and this is being compared in a 2-to-1 randomization to an investigator's choice arm. 2-to-1 meaning twice as many patients are randomized to this arm as compared to investigator's choice. And investigator's choice is not any choice, it's those specific choices there. So the trial is ongoing. Patients are treated with this oral medications until disease progression or until they develop toxicity that's not acceptable. There is also some data using darovasertib as a single drug before patients got their definitive treatment. It actually, a small trial in Australia has shown that there was shrinkage of the tumor. And based on that, this clinical trial is also ongoing. It's neoadjuvant treatment with darovasertib, and for two groups of patients. One is a group of patients that is going to receive plaque brachytherapy, but will require a lot of radiation. And the question here is whether you can shrink the tumor enough before the plaque brachytherapy that the field of the radiation will be modified and the vision loss caused by radiation may be reduced. The other group is patients that have very large tumors that will require enucleation, but they still have usable vision. And the question here is whether you can shrink this tumor enough that they may not require enucleation. You can save the eye and save the vision, and be able to treat these patients with, say, plaque brachytherapy rather than enucleation. So this is ongoing, and we're looking forward to the results of those trials that can potentially impact the practice. There are other targeted therapy. In fact, too many to count. I mean, this is sort of a miracle because, 10 years ago, I can tell you that you really had to look very very extensively to find one trial to treat metastatic uveal melanoma. Now we have all sorts of targeted therapies being used. And as I said, this is too extensive to go into a lot of detail. The point here is there seems to be now a lot of experimental options for these patients. Let's talk about checkpoint inhibitors, immunotherapy. There are no data comparing a single checkpoint inhibitor with combination checkpoint inhibitors. So we have here the data for monotherapy, just things like nivolumab or pembrolizumab, and you can see the response rates here are in the single digits, with this one exception here. And the median progression-free survival and the overall survival are really not very different from what we see without these treatments. And then you get to combination, and we're talking here mostly about ipilimumab and nivolumab, and you see a slight uptick here in the response rates, maybe low 2 digits. However, you don't really see a major corresponding improvement in the median progression-free survival, and maybe a slightly improved survival. So essentially, there's no prospective comparative data here. And if you're going to use immunotherapy in patients who can tolerate it, we consider combination. Patients who cannot, single agent is not a bad idea. But we do now have an approved treatment for patients who are HLA-A201 positive. And why is that? It's because the target of this new treatment is a protein called GP100, and GP100 is a protein that is only appropriately expressed when the patient has an HLA-A201 phenotype. If the patient does not have that phenotype, GP100 is not really seen by the immune system. And it's not expressed or expressed in the surface of the cancer cell. So this molecule, tebentafusp, is what's called a soluble T cell receptor. It's a molecule that on one end will bind very, very tightly to GP100, which is in the tumor. So it's that end is going to bind to the tumor very tightly, and the other end will bind to the CD3 receptor, which is in the T cells. So this thing binds to the cell, and then the T cells are circulating, and when they see that end, they're going to bind there, and they're going to activate the T cells and kill the tumors. So you can see here the GP100 is expressed in melanomas, 85% of cutaneous and 100% of uveal melanomas. And here you see how that binding occurs. So this is the normal T cell receptor, and this is the new construct that is soluble. So the soluble construct binds this is GP100 that's being presented by what we call the HLA, and this thing will bind to GP100 and will activate the T cells as the T cells are moving around. This is a 3-year survival data. This drug was approved based on this clinical trial. There were twice as many patients in the tebentafusp arm as there were in the investigator choice arm. And at 3 years, the endpoint of the trial was overall survival, and there was superior overall survival for the patients that got tebentafusp compared to the patients that got investigator's choice. You can see all along at 1 year, at 2 year, and now at 3 years, there is a superiority of the in survival the patients that got tebentafusp. The response rates are not very impressive, 11% versus 5%. Yeah, but the stability of the disease at 3 months is impressive. 46% for the tebentafusp group versus the investigator choice group. And here, I'm just showing you the side effect profile. This drug does have some side effects that there are mostly due to something called cytokine release syndrome. And this occurs mainly in the first 3 treatments. Those first 3 treatments have to be given in the hospital. And you can see here the percentage of patients that have adverse events over time. And you can see that most of them occur in the beginning. And then after that, only a small amount of patients with low-grade side effects occur during this treatment. This treatment is weekly, so it's somewhat difficult for some patients because every week you have to go in and get this infusion. But once you're past the first 3 or 4 weeks, most patients really don't have any significant side effects, and it becomes less of a burden on them. There are other immunotherapy approaches. There is an oncolytic virus called RP2 that is being tested now with or without nivolumab. Brenetafusp is a very similar drug to the tebentafusp, but it targets PRAME. It does not target GP100. You heard everything about PRAME before from the other speakers. And there is also this STING agonist. This is a molecule that stimulates the innate immune system in combination with cemiplimab. We also have some novel forms of treatment, theranostics. Theranostics are antibodies that are attached to a radioactive molecule, usually alpha emitters, and I'm going to talk a little bit about that. So this is the brenetafusp. This is the same construct as I showed you before, but now it's targeting PRAME. PRAME is also HLA-A201 restricted, and PRAME is extensively expressed in melanoma. That's where it came from. It means preferentially expressed antigen in melanoma. That's where the name PRAME comes from. And indeed, it is expressed widely in cutaneous and non-cutaneous melanoma, and also in other tumors that are not melanoma related. So this is the data that was presented by Dr. Hamid in ESMO a couple of years ago, looking at this brenetafusp that's targeting PRAME. You can see that there were some responses were seen in cutaneous melanoma, and in patients who did not have tebentafusp, there were also a good number of patients that have responses as well. If they had tebentafusp before, the responses were not so good. So this data in cutaneous melanoma is now being tested in an early disease trial, or first-line trial, compared to immunotherapy. So we actually have this trial open recently at our center. Unfortunately, we do not have a Uveal trial only for this drug, but I'm pretty sure that that's in the works as well. RP2. So RP2 is an oncolytic virus. It's a virus that have a tropism for tumor cells. It does not survive well in normal cells. This particular virus, in addition, has a CTLA-4-like molecule. And this was presented at ASCO last year. And in this presentation, they used this RP2 virus injected directly into metastases of uveal melanoma alone or in combination with nivolumab. And you can see here there were responses in about 30% of patients, and these responses were somewhat durable. So this led to a clinical trial that actually just activated as well, and it's going on all over the country in patients who have not received immunotherapy and have had only one prior line of therapy, and that line of therapy would probably be tebentafusp if they are HLA-A201 positive, and these patients will be at random assigned to receive RP2 plus nivolumab versus ipilimumab and nivolumab. So we're anxiously waiting for their result that hopefully will add another option to the treatment of these patients. Let's talk about theranostics. The melanocortin receptor 1, MC1R, is a protein that is expressed very highly in melanoma, as you can see here. It's really not expressed in a lot of other tissues, but in melanoma is very highly expressed. So it's become a target to treat melanoma. And this is the principle of theranostics. So we have a tumor, we have a cancer cell here, and we're targeting a protein. In this case would be MCR1. An antibody can target that molecule and will link this antibody with this alpha emitter, which is a radioactive particle. And there are two that are being tested now. There's one that's actinium-225, and that trial is being done at Moffitt. And there is lead-203, and we are doing that trial with lead-203. They have different characteristics in terms of time that they stay in the body and so on and so forth. But those are both are very legitimate ways to try to treat this patient. So this radiation is taken to the tumor, and in the tumor, it messes up with the tumor DNA. It also messes up with the proteins, the phospholipids in the tumor by creating radical oxygen species, the so-called free radicals. And in addition, once it kills the tumor, it will stimulate the immune system because the immune system will see the antigens of that tumor and maybe develop an immune response in addition to that. So I think this is a very exciting approach as well. And then we have tumor-infiltrating lymphocytes and engineered T cells. This is the first trial using TILs to treat uveal melanoma. 7 of 20 patients responded, was 35%. There was one CR that this one here that lasted a long time. And MD Anderson has an experience of TILs as well, only 9 patients, and they seem to have good responses, but the numbers obviously are very, very small. Dr. Shushtari at the Morrison Kettering just recently presented their experience with TIL, 9 patients. They did not see any objective responses there, but they saw some tumor regressions. So TIL as a thing, it's just the regular TIL that we do, for example, for cutaneous melanoma, so far has not shown a lot of promise in uveal melanoma. But I'm glad that Dr. Hernandez introduced these this engineered T cell therapy from the company Immatics, that has really shown very interesting data in uveal melanoma. And again, as you see, PRAME is very widely expressed in cutaneous and uveal melanoma. I'm going to skip to this because he already discussed this, but let me just show you the data that is available. 50% of cutaneous melanoma had a response. Some of these are what we call deep responses. And look at uveal melanoma, 67% out of 16 patients, also with very deep responses. So I think this is a very exciting molecule, or a very exciting field, the field of engineer T cells. And you can see here these responses are lasting, durable responses. So the last thing I'm going to talk about very quickly is who is at risk to develop recurrence. How do we know from the universe of patients that come with uveal melanoma who's going to be that guy that will develop recurrent disease? And fortunately, we now have a lot of information that we kind of know who are the people that are at high risk based on a lot of work from everyone globally, and particularly the work of Dr. Bill Harbour from the Collaborative Ocular Oncology Group. And based on the data from the Collaborative Ocular Oncology Group, and this was just recently published, we now know if you look at melanoma-specific survival, we now have 4 different groups of survival, and we have 4 different groups for recurrence, and these are the class 1 PRAME negative, class 1 PRAME positive, class 2 PRAME negative, and class 2 PRAME positive. And as you can see here, at 5 years, these different groups of patients had very different prognosis in terms of recurrence and in terms of survival. So why do we need to know that? We need to know because we need to figure out how to monitor these patients. Also, we may want to give patients adjuvant therapy if they are very high risk. And that brings me to some data that was generated at Dr. Harbour's lab with this drug quizzinostat that seemed to work in stopping growth or preventing growth of tumors from uveal melanoma patients. As you can see here, this is the untreated tumor. This is a treated tumor. Based on that, we have opened recently a clinical trial, and a multi-center clinical trial for patients that are at high risk based on these criteria. They have a tumor that has a diameter to 12 millimeters or larger, and they are class 2, and they can be treated up to 6 months from the definitive treatment. And our endpoint here is we wanted to decrease the recurrence rate, the distant metastasis recurrence rate at 3 years. So right now, this group of patients at 3 years, 40% of these patients will have a metastasis. What we're looking for is to bring that 40% to 25%. And here are the participating centers. We are open for approval. We're working with all these other centers to get them activated quickly. This is an oral medication that's given 3 times a week for a year, and we monitor patients for 3 years. This is another trial that is open in Europe. It's not yet open in the US, but it will be open in 5 centers in the United States. It's being led in the United States by Dr. Carvajal. This is for patients that are HLA-A201 positive, so they're the only ones that can get the tebentafusp, and patients will have the primary tumors, and then they will be randomized to receive the tebentafusp or observation on a 1-to-1 basis. And what we're looking for is we want to see a decrease in the rate of recurrence of these patients that are receiving the tebentafusp. And finally, this is in the works. This is a trial that will probably take several months until it becomes active, but this is based on data from the group from Dr. Rapiswan at Georgetown. He did a single-arm trial with a contemporary historical match comparing ipilimumab, nivolumab on these patients, looking at a control group, and the ipi-nivo in these patients seemed to have a superior outcome. But again, remember, this was not a randomized trial. So the idea is to make this a randomized trial. Now it's going to be a cooperative group trial, probably a multi-cooperative group trial. So I think this is all I wanted to discuss. I hope I didn't go so much beyond my allotted time here.